We've learned over the past decade that it is critical to screen for specific molecular alterations in our patients with advanced non-small cell lung cancer. Many of these molecular alterations now have standard, highly effective targeted therapies that need to be matched appropriately to the patients who harbor those targets. For a long time, we've had EGFR, ALK, and ROS1 inhibitors that work for patients with EGFR mutation, ALK, and ROS1 rearrangements. But now we have additional targets for which there are also highly effective therapies. So it really is a critical part of the diagnostic workup of any patient with advanced lung cancer. It's hard to know exactly what the best screening platform is, but in general, our recommendation would be to use a multiplex platform that allows testing for multiple genetic alterations at the same time, rather than doing one alteration after the other. The field of ALK-positive lung cancer has become very complicated the last 10 years. We now actually have 5 different ALK inhibitors approved in the U.S. for patients with advanced ALK-positive lung cancer. There's the first-generation inhibitor, crizotinib, 3 different second-generation inhibitors, ceritinib, alectinib, and brigatinib, and now, most recently, we have a third-generation ALK inhibitor, lorlatinib. The third-generation ALK inhibitor, lorlatinib, is the most potent of the ALK inhibitors, also highly brain-penetrable, and has the broadest coverage of ALK resistance mutations. Because the field, though, has moved so rapidly, I think there is a lot of confusion about how to use these ALK inhibitors and whether or not we should just use one after the other empirically, or whether or not we should use some type of biopsy results, molecular data to guide us. And in my talk today, I hope to show you that there is data, both preclinical and now emerging clinical data, to support using molecular information about patients' cancers to guide the selection of next-generation ALK inhibitors in particular.